introduce you, that way we can get started. So thanks everyone for joining us. Today we have Dr. Dora Ramaker from Portland State University joining us. Her presentation, titled Improving Healthcare for Adults on the Autism Spectrum, has been very well, people have had a lot of interest in this one, so we're glad to have her with us this month. Dr. Raymaker is the co-director of the Academic Autism Spectrum Partnership in Research and Education, and also the associate editor of Autism in Adulthood. She's also Research Assistant Professor at the Regional Research Institute at Portland State University. So thank you. We're very happy to have you, and I'm glad that we could get the time worked out. And with that, I'm going to hand it over to you.
Great. Thank you. So thanks again so much for having me. As Melina said, I'm faculty at Portland State University's Regional Research Institute for Human Services, and I'm the co-director of the Academic Autism Spectrum Partnership in Research and Education, or AASPIRE, and I conduct community-based participatory research with the autistic, disability, and mental health communities. And my focus is on social services intervention. So I'm a social service intervention researcher. I do mostly employment and mental health research, but I've also been working on this healthcare for autistic adults with ASPIRE for over a decade at this point. So you'll be hearing all about that kind of huge work that ASPIRE has done. I'm also a member of the autistic community myself. So in my work with ASPIRE, I kind of straddle both worlds as PI on my own research projects, but also I came into ASPIRE as an autistic advocate, a self-advocate. So kind of in between, and I've been a long time kind of human rights advocate, as you can see from my impertinent women's lib baby picture. So my whole thing is science for social change. Just a quick note on language. In this talk, I will be using identity first language with respect to people on the autism spectrum. So I'll be using autistic person. I know many of you have been taught to use person first language or person with autism, but the autistic community feels kind of similarly to the deaf community about the way that we get called. So in general, though, I advocate for person-centered language, which is to use the language that the person themselves actually wants. And I'm happy to answer questions about this in the Q&A at the end of the talk. So today, I'm first going to give an overview of ASPIRE and community-based participatory research, so you kind of get the context of where this information comes from. And then I'll get into some healthcare disparities and barriers to healthcare for autistic adults, followed by ways to understand and reduce some of those barriers. And then finally, I'll show you the ASPIRE Healthcare Toolkit and the Autism Healthcare Accommodations tool that you can use in your practice with your patients or with the people you support, or maybe with yourself if there's anyone in the audience who is like me. So just some frames about where this comes from. So ASPIRE was founded with my partner, Christina Nicolaitis, who is the medical doctor and public health half of our collaboration, 14 years ago, when she lured me into a conversation with promises of reading autism papers because she knew that I was interested in science. We read about maybe 3 of those before the issues became really overwhelming, that autism research was not very useful or relevant to our lives. There were some really bad research designs because the researchers didn't understand what the experience of being autistic was like. There was research that was stigmatizing or stereotyping or further marginalized us in certain ways, or maybe even had the potential to cause harm. But fortunately, community-based participatory research is an approach to science that was designed to help with issues just like those. So CBPR is an emancipatory approach to research that was developed from within public health. It's been around for a while now. It takes an equitable approach to science. So the idea is that community partners serve as co-researchers with academics in all phases of the work, from figuring out what you're going to study all the way through to disseminating it into all of the communities. And the lived experience and community knowledge of the non-academic partners is valued equally to the academic expertise. Autistic adult and other community stakeholders, including healthcare providers, clinicians, and supporters, were involved with all stages of this healthcare work that I'm going to be talking to you about today. So we've now been working on healthcare projects for nearly 14 years, because that's the place we started at, and over multiple National Institutes of Health funded projects with a lot of learning. And I am really, really proud of who we are today and what we've done. These are by no means pictures of everyone who has had their hands in this work, but it shows a fair number of them. These pictures are from 2018 and 2019 when we had some in-person retreat. And this work that I'm talking to you about is collaborative and collective and all of ours. So yeah, so it's been going on. We've been actively doing this funded in a funded context for 10 years now. And there's a slide at the end that has the citations for all of these. I assume you'll be given the slide set, but if not, you can also email me and I'll send it to you. I also am happy to send you the actual papers. If you have trouble with paywalls, I've got them all. So the very first study we did was a survey of autistic adults, non-autistic adults with disabilities, and non-autistic adults without disabilities. And that study included a survey of barriers to healthcare. We then did a qualitative study to better understand the experiences of autistic adults, their supporters, and their providers in healthcare, to better understand and explain some of the disparities that we saw in the first survey, and to also get some new information about what we might be able to do about this. We used this and the expertise of our CBPR team to develop and test the AASPIRE Healthcare Toolkit. More recently, we conducted a larger project on integrating the toolkit into various healthcare settings. And as part of that, we surveyed providers about their confidence in providing care to adult autistic patients. So I'll be talking about the findings and recommendations that are from those studies. We also have some new patient measures for assessing healthcare interventions, and we had a lovely Fulbright scholar who was with us last year from Australia, who she led a qualitative study about hospital experiences for autistic adults. And I'll share a little bit about her findings, but that's not as much the focus of this today. So this is kind of just the disparities and barriers to care. So as you probably know, autistic adults have worse health and healthcare outcomes than the general population, which includes more frequent co-occurring physical and mental health conditions, higher rates of mortality and morbidity, greater healthcare utilization and costs, higher use of emergency departments, lower use of preventative services, more unmet healthcare needs, lower satisfaction with patient-provider communication, and more barriers to just receiving care even in the first place. And that's not just us at this point. There's a large body of research that has been done that has explored the basic bigness of the problem. Since I'm going to be talking mostly about barriers and ways around them, I'm going to go into a little bit more detail on the work that we did on understanding them. So in our healthcare disparities study, we included a measure of barriers to healthcare that had originally been developed with a cross-disability community. It was a community academic partnership at Oregon Health and Science University. And we developed it further as a team to include some items that our autistic community partners felt were particularly important, such as items about sensory barriers that hadn't been in the original instrument. So the survey broadly included items around emotional, cognitive, healthcare system, provider attitude, communication, sensory, socioeconomic, support, and facilities type barriers. We have both short and long-term and long-form measures available, which exhibited some good initial psychometrics and responsiveness to change. And they could be useful actually in intervention testing, or even maybe as a broad idea for what barriers are being experienced by someone. Using the long form, we surveyed 209 autistic adults, 55 non-autistic adults with disabilities, and 173 non-autistic adults without disabilities. And we matched for age and gender. And the autistic sample selected both different and greater numbers of barriers than the other two groups. So these are the top 10 barriers for autistic adults. The top one, fear or anxiety, was actually, so that was selected by more than a third of the autistic sample. That was actually the top barrier for the non-autistic samples as well. But for the people without disabilities, it was only by 10% of the sample. So you can see that there was a 20% difference in even what was the biggest barrier. Or people even having a barrier in the first place. So the next in order of how many people selected them were not being able to process information fast enough to participate in real-time discussions about healthcare, concern about cost, facilities causing sensory issues, difficulty communicating with providers, not understanding how to use the healthcare system, sensory issues making it too difficult to communicate, social isolation, embarrassment, and worry that the stress of interacting with the healthcare system will cause a meltdown. The issues with quality healthcare access for autistic adults isn't just barriers that reside with the patients on their end. There's also increasingly documented issues with healthcare provider knowledge and self-efficacy on their side. ASPIRE created an adult autism healthcare self-efficacy scale to measure provider competence based on what we learned from our qualitative studies and the expertise of the clinicians in our group. And we used it with 143 internal medicine and family medicine primary care providers across different settings. So the results, which were consistent across setting practice and practice type, were that only a quarter of the providers felt confident communicating with adult autistic patients. Only 43% were confident performing exams or procedures. Only 40% were confident accurately diagnosing and treating non-autism related medical issues. Only 38% were confident that they could help their autistic adult patients stay calm and comfortable. And then only 14 to 15% felt confident identifying and making accommodations to improve healthcare access for their patients, which is where hopefully some of the tips we have come in. So how patient barriers, provider barriers, and system barriers interact is something that's being more and more explored in this population. There are multiple models out there that are similar to this. This is from our qualitative study with patient level factors such as communication skills and sensory sensitivities, body awareness, processing speed, atypical communication, and organization challenges. That all interacts with the provider level factors, such as how knowledgeable people are about autism, how correct or incorrect their assumptions are about individual patients and their abilities, because as you know, autism is very heterogeneous. Their ability to accessibly communicate, their openness to providing accommodations, and their skill in integrating a patient's supporters when they exist. And all of that exists within the context of the broader world, where there are system level factors, including stigma and discrimination, availability of supports to the person, the healthcare system that it exists within, and all of that kind of as a lump leads to the success of somebody's ability to have a good healthcare interaction. So that was a whole lot about the problem in a kind of numeric sense, but I would like to focus now a little bit more on gaining a deeper understanding of what's behind these numbers, and more importantly, looking at what some of the solutions might be to getting rid of them. So the first big category here is about communication and interaction that's going on between the patient and the provider. One of the things that people, autistic patients experienced and their supporters also experienced, was that there was a high potential in the healthcare systems for faulty assumptions about the patient. So for example, some people who were non-speaking felt that translated into providers thinking it meant that they were also non-understanding. So this person said, just because I have difficulty expressing what is going on with me doesn't mean I am stupid or that I am making things up. On the other side, people who have fluent speech aren't always communicating adequately. So this patient said, usually when I demonstrate a large vocabulary or some fundamentals, my needs, especially around communication, are ignored. My choice is then to pretend to be less intelligent and accept their infantilism, or to be confused, frustrated, and stressed out. And then patients also talked about needing a specific mode in order to communicate effectively, especially in these stressful situations. So this patient says, I prefer and find it easier to communicate in text, but with every doctor I speak to, they wave away the note card and look at me to ask the same question I have just answered and interpret my confusion as being non-compliant with the medicine. I wish healthcare providers would read the notes I made for them. I wish they would be patient as I pause a lot and stutter when I am overloaded. So here are some tips that we have for dealing with those. First is for providers and offices to get really explicit, individualized information on the patient's ability to understand spoken language, to speak back, to read and write, if they use any alternates to speech to communicate, what their preferred mode of communication is, even if they're able to do multiple modes. Their ability to use the telephone. A lot of us have trouble with telephones, and you can't assume that they can be used. And the degree to which communication normally varies based on environmental factors or stress, because it may not be consistent depending on what's going on. And then for the provider and the office staff to attempt to use the most effective communication mode for the patient, even if that means it's not what the provider usually uses. So another communication related thing that we heard a lot about was the need for literal and precise language, where language pragmatics, so the social use of language, can sometimes be a bigger barrier for this population than the vocabulary itself or the sentence complexity. So this is a quote from somebody, a supporter of an adult child who related. They asked him on a level of 1 to 10, where is your pain? First time he said, how do you weigh your pain? I don't weigh my pain. And then this is from a patient. How do you feel? Too vague. Can you describe your symptoms? I can somewhat answer this, but not fully. It's a starting point, not an end point. Specific questions related to symptoms are good. Does your side hurt? Are you keeping food down? And we also heard a lot about anxiety of people who didn't feel like they could answer a question, particularly a general question, precisely enough. And that really heightened people's anxieties. So here are some tips around language. Of course, be very concrete and specific, which sounds obvious, but is actually very, very difficult for people to do, especially providers who have been taught to open patient interviews with general questions. So it's almost like they need to be retrained to do things in a different way. Avoid figurative expressions and figures of speech like weighing your pain. Avoid broad questions. In some cases, some people may need mostly closed-ended questions or even ones that patients can answer with a yes or no. Or they might be able to answer better if some examples or specific instructions are provided. Showing patients a list of symptoms to choose from can be helpful. Giving examples of the types of things people might experience and have the patient tell you if they also experience them. Reminding patients that it's okay not to know the answers to questions or to not be exact, to kind of help with that anxiety about specificity. Give patients very direct and concrete examples when discussing your assessment and plan. Be blunt. And direct patients to detailed information or resources about their health conditions and treatment options if that would be appropriate. So language, of course, is not just what we say, it's what we do. We heard a lot about people having difficulty processing body language or self-regulating or managing stress, and that would make providers or office staff make assumptions about them that weren't actually the case. For example, lack of eye contact or stimming in the office was sometimes misconstrued when all it was a way for somebody to manage their stress or to pay better attention to a difficult topic. So this patient says, don't assume no eye contact means we are not listening or are being deceptive. It is often a way we need to behave to regulate incoming stimuli and not be overwhelmed by too much at once. So some tips for that. Don't, of course, try to force a patient to make eye contact. This happens to me a lot and it's very unnerving. Don't assume a patient is being rude or trying to signal something if they are pacing, not making eye contact, humming. Sometimes they have to just be told explicitly, look, I'm going to act like this. It's not what you think it means. And then just letting patients stim or behave in self-calming ways will help them be comfortable and able to take in information. So the kind of allowability and the giving permission to do that can help. And then remember the processing speed issue was pretty much the #1 barrier after that common fear that kept people from being able to participate in their healthcare. So slow processing, of course, impacts communication, but it's also related to responses to sensory stimuli. So indicating if something is tender or if you can feel something before the provider moves on, as well as the ability to make decisions quickly in high stress situations. So this is a quote from a healthcare provider we talked to. It might take a while for a patient to effectively communicate. It takes them a bit extra amount of time to process questions, process information, and sometimes their responses are, going to be more delayed than, say, the typical patients might. For instance, if the patient receives questions or information to describe or identify their conditions or symptoms, they might not be able to answer right there. They might sort of need to go home and kind of think over it and then be able to answer the next session or even call in and describe it. So some strategies for that, just realizing and making space for giving patients time to answer, to process what has been said, making sure explicitly, are you ready to move on? Do you need more time? Giving patients extra time to process the things they need to sense before they respond. Have you had enough time to tell if, do you want me to keep pressing? If possible, schedule longer appointments. I know that's not always a reasonable tip, but encourage patients to prepare notes in advance about what they want to discuss, and make sure that providers and staff carefully read the notes that patients bring to the visit. It's not just there to slow stuff down. Write down important information or instructions so patients can review it later outside the office. If appropriate, direct patients to detailed information or resources about their health conditions so they can review them on their own time. And if necessary, give patients time to make a decision and communicate at a later time or schedule up a follow-up for it. They may also need to talk it over with a trusted person. So the next kind of big group after communication stuff is sensory issues, and everyone has sensory issues in healthcare. Many people don't like fluorescent lights, but not liking fluorescent lights for most people doesn't make it actually impossible to talk to their doctor. So it's important to understand that these sensory issues are not to be brushed aside because everybody experiences them. It's a different level. So this person, this is actually one of my favorite quotes because I think it's just a really good description of an experience. Relates, I have just traveled to the office on a very loud bus or train. The lights in the office are very bright, and that is exacerbated by the white walls. Sometimes the waiting rooms are crowded, and I cannot filter out the background of people talking or shuffling magazines. I feel disoriented by being led down long hallways to different rooms. I'm not able to bring up my concerns because it is all I can manage to figure out what the doctor is saying so I can respond to his questions. So sensory issues, some ways around some of those. When possible, if somebody is light sensitive, use natural light, turn off fluorescents, make the lighting dim. Try to see the patient in a quiet room, if possible. Have only one person talk at a time and try not to talk to the patient. If there's another noise, beeping, screaming, just wait for it to pass. Avoid unnecessary testing of the patient, for example, to express concern. Warn the patient before you're going to touch them so they can prepare and they know when it's expected. And encourage patients and supporters to bring objects to reduce or increase stimuli. So, you know, the office can be noisy at 3 p.m., bring some headphones. It's bright in here and I can't do anything about it. You may want sunglasses, things like that, sensory items. So there was a whole lot of people have the sensory things extend into body awareness, pain awareness, and other aspects of sensory processing other than just being sensitive to the stimuli around you. This includes difficulty discriminating abnormal from normal body sensations, pinpointing the location of a symptom, describing the quality of a sensation. Some of us have really hugely hyper or hyposensitive pain thresholds. Some of us have difficulty recognizing normal body stimuli such as hunger or the need to urinate. And here are two quotes about that from different autistic patients. I don't know my own body. So when I feel all of these different sensations everywhere, I don't know which is the real problem and which is just sensation. The problem is it is difficult for me to isolate specific sources of pain and identify duration and intensity. It's sort of like the equivalent to white noise. So unfortunately, we haven't really figured out some really great ways around this. One is just to be aware that it's a thing that could be happening. Awareness always helps. So consider the possibility that differences in body awareness might be affecting how the patient recognizes or describes a symptom or how they respond to their illness. It's possible you may need to do additional testing or imaging because the information from the patient's experience might be limited. Okay, so the next kind of big category is need for consistency, which I'm sure we all know why that's important. This patient says, meeting new people is very difficult. So when I was always shuffled to a specialist, it was extremely scary and anxiety provoking. So before a visit, some things that staff can do to help with that is to let the patient or their supporters know what is likely to happen during the visit. Avoid rescheduling appointments if possible, and notify patients as quickly as possible when the schedule changes. Prioritize their notification. You can give them pictures or let the patient or supporter take pictures of the office or staff to get used to it or to know what's coming up. When the patient checks in, let them know how long the wait is likely to be and give warning if there's an unexpected delay. And I know that you can't often tell. Like that's, you can't say, oh, well, exactly, we are running exactly 20 minutes behind. But even saying that there is an uncertainty, that we're running behind and we actually don't know by how much, it could be 5 minutes or it could be an hour, that's something specific that people can hold on to, and they know then what the range of expectations is. So there are ways that you can give something specific even in an uncertain situation. So this is not true of every autistic person, and nothing that I am describing here is a universal experience, because again, we are all aware of the heterogeneity. But some people have really concrete or visual ways of thinking. Some people have trouble with the abstract nature of time and time questions. Sorry, my cat is telling you she's never been fed in her whole life ever. So you can help patients answer questions about time by linking to important events in their lives. Like, this was around the time of your birthday, do you remember? You can work with the patient to explain time-based recommendations. For example, help them set up an alarm for when to take a pill, or link the action of doing something to, if it's somebody who has a well-established kind of very rigid daily routine, link their treatment actions to the things that are already happening in their routine. For visual or concrete thinkers, you can offer diagrams, pictures, models, and also create, or have your staff or the supporters create, or work with the patient directly for them to create themselves visual schedules or visual instructions for recommendations. And then there's this whole area of, quote, executive function, the kind of keeping things organized, keeping track of things, sequencing things, which a lot of us struggle with, and can really hurt people's ability to navigate an already complex and difficult healthcare situation. So here are just two experiences that come from patients. So this person relates, with my autism, it is very difficult for me to understand and follow all the different appointments and procedures I have to schedule and how to do it. And no one will help me, since apparently people magically become competent at these things before they turn 21. This is getting into some of the transition issues. Another person says, it's like having a list of 100 things you have to get done right away, which you must memorize orally in the 5 minutes you spend with the doctor, and then execute without error, even though you don't understand how to do half the things you need to do. So some ways to help with that are to write out detailed step-by-step instructions for the patient to bring home, much more detailed than you would for other patients. Show patients what you want them to do while they're still in the office, have them practice. Have office staff help the patient schedule their follow-ups, referrals, or tests. Use the staff to provide some support. Show or have someone show the patient how to get to other places in your office or medical center. Sometimes just navigating through space is too much, even if it's, down the hall and 2 doors over. Have office staff contact the patient or their supporters after the visit to make sure that they've been able to follow up. Sometimes, again, in the the things flying at you too fast in the appointment, you get home and are like, wait, what just happened? Give patients worksheets or diaries to keep track of things, and give the patient detailed information about how to communicate with office staff between visits. You can't assume that all of the steps for knowing when I should call, how I should call, overcoming anxiety about the telephone, like all of those things can be met. Don't make assumptions, get explicit, and have a plan. So all of those things, you know, sensory issues, communication, body awareness, all of those things that I just kind of ran through are factors when exams and procedures are actually being done. So here are some additional tips that we have for accommodating exams and procedures. So the first is just to explain and tell the patient what you're going to do before you do it. I am going to lift up your arm. I am going to press this cold thing to it. All of these things before it actually happens, and with times. I am going to press it to you for 30 seconds. Show the patient equipment or pictures of equipment before using it. If possible, not always possible, but you can let patients do a trial run of a difficult exam or a procedure. Practice it first. Tell them how long things are likely to take. They know then how much they have to kind of hold themselves together during an uncomfortable situation, or at least have some idea of consistency or when it's going to end. Warn the patient before doing something. Limit the amount of time they might be undressed. This was a tip that we got from some people who said that they were very, very sensitive to heat and cold, and that the coldness of being undressed was really impacting their ability to relate to the doctor. Give patients extra time to process things they need to see, hear, or feel. We kind of talked about that, and the extra processing time. Allow the patient to sit, lie, or lean on something for people who have motor difficulties. Let patients use a signal to tell you they need a break. They might not be able to communicate it verbally normally. Ask the patient from time to time if they are able to handle the pain or discomfort. Again, they might not be able to communicate outward, but can respond to a prompt. For some people, there's just nothing you can do, and anesthesia ends up being needed. Not every autistic person has difficulty with blood draws, just like not every non-autistic person does, but for those who do have difficulty with blood draws, it's a really, really big deal. So some things that we heard helped people is to group blood tests so that you can minimize the number of draws, lying or leaning on things, numbing spray or cream, being very patient, using a calm voice, not doing anything startling. Some people liked having a really detailed explanation of what would happen, including how many tubes of blood you will fill. Consider anti-anxiety medication for some people. And then this is, I mean, it's going to sound contradictory, but again, we're talking about autism heterogeneity. Some people liked plenty of advanced warning so that they could prepare themselves emotionally for the coming needle. But other people were like, no, what you need to do is distract me so I don't even know when it happened. So a lot of these things are going to be highly individualized. And that's part of why I kind of like to talk about what the underlying experiences are and what the sort of general issues that we're trying to accommodate are, because this is like reasonable accommodations in the workplace under the ADA. These are all things that are negotiations between the patient and the providers, and it's going to be highly individualized and specific. These tips are just a starting point. They're things that we have heard help other people, and yes, so that is that. So happily, even though that is a huge amount of information that I just dumped on you, you do not need to memorize it or have taken furious notes, because it's actually handily online in our AASPIRE Healthcare Toolkit, which I'm gonna walk through a little bit next. So I'm gonna escape out of that and just kind of do a little show and tell. Here is the front page. It's got one side for patients and supporters, one side for healthcare providers. On the healthcare provider side, there's this section caring for patients on the autism spectrum, which is all of the information that I just gave to you through that last section. There's also some information on adult diagnosis, some legal stuff, some resources, and then links to things that patients might want to use. And then over on the patient and supporter side, we have these sort of downloadable checklists and worksheets to help people manage their appointments and follow-up care and understanding, like, what do I need to do and have together in order to just schedule an appointment. There's healthcare navigation information about how to do things before, during, and after the visit. Some health stuff, some HIPAA stuff, and some extra organizational stuff. So that's all here. There's PDFs that can be printed out if you don't want to use the internet. And then there's this personalized accommodations report. So briefly sort of switch back to here. So before, or right around the time that I started working with Christina on these projects, I had an appointment with a neurologist about migraines. And I wrote up this like highly detailed list of accommodations that I needed in order to get through this appointment. And it was, you know, beautifully spelled out on like 3 pages, and I write well, so it was all, you know, polished. And I gave it to the neurologist, and she looked at it and she just tossed it aside, completely unread, and the appointment blew up and it was terrible. And Christina shares, she's an internist, and she shared an office with another internist, and she idly mentioned, oh, I'm working on this autism healthcare project. And he said, oh, that's great. Let me tell you about this experience that my wife had. This autistic patient came in with like 25 pages of accommodation needs. And she took one look at it. It was like she didn't know what to do. It was overwhelming. And as they started talking, it became clear that his wife was the neurologist that I had gone to see. So the whole purpose of this autism healthcare accommodations tool was, how do we translate things out of this highly specific patient way of communicating needs into something that is going to accommodate the healthcare provider who is so busy and overwhelmed that it almost turns into a disability in itself. You know, we started laughing about this project because it almost felt like more disability accommodations were needed for the provider than for the patient at some point in getting this report out. So what the AHAT does is that a patient or a patient and their supporter would fill out a survey about what's going to help them access healthcare. And then there's a little translation program that turns what they checked off into more succinct provider speech with all their jargon, and then reformats it into a report. We worked with a bunch of providers to try to find something that didn't immediately overwhelm them and make them want to throw it to the side, like my experience with the neurologist. So this is what it looks like for the patient. It's just a very simple checkbox survey. You can actually pick more than 3 suggestions. This is an older version on my slide. But they'll be prompted with a question. So this is what can help you make good decisions about your health and healthcare. and you pick up to 3 suggestions, or whatever suggestions you want. And then these are things like, give me extra time to make a decision, even if it means I need to come back, give a person I trust detailed information. So these are various accommodation things. So just to give a little sample of what that ends up looking like, it starts out with a cover letter on OHSU, PSU letterhead. It's got customized information with the patient's date of birth and their name. There are some things to help people schedule or help with transportation that would go in there. Then it's got a section on how the person communicates and communication accommodations. Then it's broken down into these sections of recommendations for specific things that happen within the healthcare setting. It's got a section on how to understand the person's unique, the way that their autism traits might express themselves in their office, any sort of triggers, meltdown triggers to avoid. It's got a section broken out for the staff, so that would go to providers. The providers don't even need to see this part. This is for the front office staff, for some of the sensory stuff, blood draws, and then there's a page on sort of provider information, because providers, supporter information, because we heard from a lot of people that providers didn't actually understand how to use the supporters. They would sometimes look to them at times when they should have been talking to the patient, or talk to the patient when they should have been talking to the supporter. So this includes what role the supporters are supposed to take. So that is what that ends up being like. And then this is my last little fun bonus. So I told you we had a Fulbright scholar working with us, and she did a project on hospital experiences and put together this sweet little video that I'll play, and then I will do questions.
In 2019, the Academic Autism Spectrum Partnership in Research and Education conducted a world-first study on improving the hospital experiences of autistic adults. We interviewed 42 participants, including autistic adults, their supporters, hospital providers, and key informants such as nurse managers. Based on our findings, here are 5 ways to improve hospitals for autistic adults. Communicate in an accessible way. Ask your patient about their communication preferences. Use clear and concise language. Consider using pictures, models, or writing things down. One interviewee said, use close-ended questions when you can. They are easier for a scared autistic person to answer. Do you need anything else? Is helpful, but not as helpful as, is this light level okay? Reduce sensory stimuli. Many autistic people experience sensory sensitivities. Ask your patient about their sensory preferences and provide necessary adjustments. One interviewee described their experience. The hallway was bright and loud, full of beeping, passing people, buzzing fluorescent lights, talking staff. It was too much. Provide routine and certainty. Explain procedures and timelines where possible. Any certainty you can give your patient can be helpful. However, if there is uncertainty, tell them so. Especially difficult for me as an autistic person was the uncertainty of the timeline. It was not clear for hours whether a joint specialist would be available. During lulls between visits from doctors and nurses, I was constantly afraid that the staff had forgotten about me. Allow stim and comfort items. Where possible, allow your patient to keep stim and comfort items such as their phone, colouring books, notepads, and blankets from home. One of the times that I was there for psychiatric issues, they put me in a bed in the hallway and took away all of my stim toys and comfort items. Ask before doing. Ask your patient's permission before doing any examinations and procedures. Check with them if it's okay to talk to their supporter. Please ask your patients if you may touch or examine them. Please do not command them to do anything. Commands can come across as intimidating and can frighten your patient. Visit aspire.org to find out more about this study.
So autistic adults experience significant disparities in health and healthcare, including barriers that are different from others, but you can help with reasonable accommodations. And we have some tips as a starting place and the accommodations report that can be used to help. So thank you, and the Aspire team and our research participants who actually gave us all that information. I am the associate editor for Autism in Adulthood, so if anyone has articles, consider submitting. Also, that might be research articles, but we also have a section for providers, autistic people, supporters, called Insights, that you can contact me if you're interested in an insight. And there's my contact information, so open it up now.
Wow, that was a lot of really good information. I was like making notes on all different kinds of things, like how can I share this toolkit? This is wonderful. Our families need this so much. So thank you for that. I'm gonna open it up to everyone on the call. Does anyone have any questions for Dr. Raymaker? And please remember, you may be muted.
Would you prefer I stop sharing my screen? Or should I leave the
Sure.
slide up? That way you get my face real big.
Okay, it looks like we have a message in the chat. This is a wonderful training. Thank you so much.
Hi, Melina. It's Grace.
Hi, Grace.
Hi. So this isn't, well, this will lead into a question. One of my colleagues who's a speech therapist shared a great resource about how we model communication, because I was thinking of AAC devices. Whenever we're asking people to use a device, but we're expecting them to do it with our spoken language instead of modeling with them and communicating with them using that same device. So I'm wondering if Dr. Raymaker has any tips or resources for learning about augmentative communication devices, or possibly sign language, so we can communicate with people in their preferred method, if that makes any sense.
Maybe, I mean, as a speech pathologist, I'm sure you actually have access to way more resources than I do as a system scientist who does you know, services work. I can interestingly speak a little bit from personal experience, because the neurologist story that I related, I'm one of those autistic people who, depending on what's going around, may be more or less functioning. And at the time, I was relying heavily on a speech device that was outputting, it was doing a text-to-speech. And that was one of the things that the neurologist just couldn't handle. So I kind of feel like there's a preparation that providers need to have, of like, this is going to be slow and you need to be respectful, because the providers are going really, really, really fast, and everything to them is a big rush. And I know that this isn't their fault. It's the way that one of the many ways our system is broken. But I think it is particularly puts people who are using speech devices or letterboards or picture boards or whatever at a huge disadvantage because of just how slow it is. So I don't think you're going to be able to get most providers in a typical primary care setting to use AAC back. If it's, you know, if it's a very dedicated provider and it's a long-term relationship, maybe. I would focus just on getting them to respectfully give people time. Like, I don't know that we're there. I don't know that we're there in the place where the model back is even possible, which might be pessimistic, but
No,
I don't know if that addresses it, but those are my thoughts.
No, thank you so much for your answer. It means a lot, and I'm really thankful for this training because it's not only sharing information that is becoming more published, but it's also making aware and also driving more toward that acceptance. So thank you very much for this training and for your answer.
Yeah, and I do think that the more, I mean, it's one of those systems are very, very slow to change. Complex systems, the more complex, the slower it takes to change. And it's not like you can implement a policy and everything gets better. I think that the more we normalize asking for accommodations in healthcare, and the more we normalize autistic adult patients being even in the community healthcare settings, all of that works toward improving the situation over time.
Great. Does anyone else have questions for Dr. Raymaker?
I do. Hi, this is Elizabeth. It's nice to meet you. I just finished my MSW this spring and just got a job here at the CED. My professional pathway that I'm trying to forge is more on the autism in the adult arena. Is what I want to talk about. There aren't a lot of services for adults in West Virginia, just like there aren't a lot of services for adults anywhere on the spectrum. So I'm wondering, what national level organizations would you recommend that we at the CED could reach out to, or me, who's somebody who's trying to build that more, both locally and at the state level, to look for resources that either don't exist yet or might exist?
So, I mean, I'm sure that you already know all of the big groups, like, you know, the Autism Society of America. And I mean, the AUCD is actually, if somebody had asked me that question in a different context, I would have been like, oh, contact your local AUCD. But I think some of it, as you've kind of rightly pointed out, doesn't really exist. This is a place where I can kind of plug the community-based participatory research model, and especially as you're connected to AUCD, sometimes building these sort of, and this is kind of the path that I'm on, and I work inside the School of Social Work, so I'm not a social worker, but you're in my world.
Yeah.
You need to get resources in order to develop, implement, and test out services. And that's a place where I see an ability to get money and resources is to, if you can partner with social workers who are doing research, the National Institutes of Mental Health are willing to fund interventions for adults. And I was recently, actually it's not that recent anymore, a couple of years ago, our program officer at the National Institute of Mental Health put together a conference for everyone who had been funded through the NIMH to do autism services research for adult. And there were 17 of us. That was it. In the whole history of the NIMH, only 17 principal investigators had gotten money to do intervention research. And so when people come to me and they say, you know, why isn't there more research happening? I see it as not enough principal investigators to do this. Like, that pipeline is inhibited just by the research side of it. So I think as a more community-oriented or provider-oriented MSW, working with AUCD researchers or researchers who do intervention research, taking advantage of, like, there's an NIMH mechanism to change your current senior research path into adult services. They actually are looking so hard for people to fill this gap that they will fund a senior researcher to retrain themselves. So if you can find people within the AUCD who might be interested in going in together on, it doesn't have to be big NIMH, it could be something like the Organization for Autism Research, which I review for them, does applied autism research. There are places out there where your partnership with a research entity could enable you to create some of the stuff to fill the void. If you have such ambition, that's one possible path open. Community campus partnerships are a great thing.
Thank you.
Sorry, I was muted. Okay, well, I want to be considerate of people's time, so I just want to mention a few things that are in the chat. A lot of people saying, fantastic work, thank you so much. A lot of people are interested in the online toolkit, some other resources about the Job Accommodation Network, askjan.org. So I definitely think that you might have some follow-up questions after this, but I really want to thank you, Dr. Raymaker, for presenting with us today. And this training has been recorded and it will be uploaded on the CED's website for those that have missed it or are unable to join us. So I think that the resources that you shared will continue to be passed on. So thank you very much.
Thank you all for having me, and you can just email me with any thoughts. I'm around.
Great. Thank you so much, everyone. You guys have a good day.
Thank you.